All right, welcome to our webinar, Wellbeing Leadership in Higher Education. I'm Joonas Merikko from AnyAdvisor, and I'm pleased to host this event in collaboration with the COHO Network for Student Wellbeing and Guidance. So let's begin. Our first speaker is Eric Carver, an expert in student guidance and quality management at the University of Helsinki. He also hosts the podcast Student Guidance at the University. Eric will now give us a short introduction to today's theme and explain its relevance.
Thank you, Joonas, and thanks everybody for participating and watching, of course, and for our guest lecture that Mantaro will start after my presentation. I was asked to make some introductory notes before the main event and share my thoughts a little bit about where we are, I think, in the Finnish context when it comes to well-being leadership in higher education. So I'll speak very briefly, and then Dr. Mantaro will give his presentation and focus more on the U.S. context, which is the main topic today. And then we'll have a Q&A session. I have some pre-prepared questions for Dr. Mantaro, and then all the participants, of course, you can also share your questions through the Q&A, as Joonas has said. The way I see where we are now in the Finnish context, and of course I just come from one university, but through the COHO network I've been able to talk with a lot of colleagues with also in the universities and University of Applied Sciences, so more a broader view through that network. And I think there's a fairly strong consensus that well-being leadership is very important in higher education, and that investing in well-being for students is important. We have a mental health crisis, and a lot of our students struggle with well-being problems, be they short-term or long-term. We still have remnants from the pandemic, and a lot of well-being losses that were created during that time are still with us today. We are a graying nation, a nation that is shrinking in terms of the workforce, and all the future graduates are very much needed in the workforce and in the society as a whole. So student well-being is a very major ethical and economical question for the whole society. My take on this is I've never met anybody who's against well-being. Everybody is for well-being. And if you review strategies in higher education institutions, student well-being is a priority there already. I haven't read all of them, but the broad, I think, view is that the well-being as a word and as a concept has seeped through in kind of the strategic leadership layer as well. But then I think it gets more dicey. What are we really for when we are for well-being? And what does it actually mean to support that? And what kind of operations, resources, strategies, thinking, services actually requires? And then it gets more interesting in terms of conversation on what should be invested in and what not. To honor our new elected president, I have 2 slides with 3 points in them. Cultural reference to Dr. Mantaro, our current president. He knew when he entered politics, he would always use 3 points when he was carrying a message forward. So there's 3 reasons why I am optimistic about the development of well-being leadership in the higher education sector in Finland. The ability to study model developed by the Finnish Student Health Services, or YTHS as we call it, is a research-based framework based on actually workability or work-based models developed for occupational well-being. And this is a good model because it helps the institutions to narrow down and identify the kinds of things that are relevant for student well-being, and also the kinds of things where we can actually approach, discuss, and develop. And if you look at the model, a lot of you know it already, so I won't go through it, but there's a lot of things we can do with study skills, teaching services, and study environment where we actually have influence over well-being. And that is something very important. You have to have a framework for leadership, I think. I think also the second reason I'm optimistic is that there's a more systematic view of well-being that's emerging. The understanding that how the academic faculty is doing their well-being, how the supporting services, people working for those services are doing, and the well-being of the students is all interconnected. And that helps us, I think, to do kind of a holistically move well-being forward. I'm optimistic about how data is more, the quality of data is getting better, and the way we use data for leadership is getting better. And of course, as research institutions, we need to be even better at using research knowledge when we develop the well-being services. But there's also some fears I have, and these are kind of the flip sides of my optimism. If we don't have a framework, or a particular university applied science starts to roll out, okay, let's do well-being. But if there's no framework for it, no research-based idea of what we're doing, or there is no clear strategy or systemic thinking behind it, or that it's not based on data and analysis of data and research. And I present you AI art original I just made for this presentation, and that's the Don Quixote Wellbeing Leadership model that you can see over there. So these are, so if things don't go well, that's my fear how the end result will look at. So there's a lot of pump, a lot of riding up the hill, but maybe not a lot of results that are tangible for our students. Those were my opening thoughts. I'll give the floor to Mr. Mantaro.
Keynote speaker is Dr. Thaddeus Mantaro. Dr. Mantaro is the Dean responsible for student health and wellness at Dallas College, Texas, USA, and he holds a PhD in higher education administration and specializing in well-being leadership. And he is also currently co-editing a book on this topic. So please welcome Dr. Mantaro.
Thank you, Eunice, and thanks, Eric. I really appreciate that introduction, and I appreciate the framing that Eric gave us for this conversation about student affairs and student well-being and the leadership of well-being programs. This is my area of interest, and I'm just really excited to be here today to present to you. I'm going to talk for about half an hour or so and share my screen in a second. Eunice and I met at the European Conference for Student Affairs and Services, and so I'm really interested in this dialogue across the ocean between Finland and the United States, and excited to share some ideas from how we operate within the U.S. I have a degree in higher ed administration, and I'm going to share some details for how things work in the U.S. Eunice and I talked quite a bit about the fact that there are significant differences between the way things are structured in the U.S. and the way they are in Finland. So, as Eunice said, I work in higher ed administration at Dallas College. Dallas College is a large community college in the Dallas-Fort Worth Metroplex. I've been here about 3 years. I have worked in higher education for about 25 years, starting off in residence life, also working in other areas like civic engagement and working as a coordinator. Across that time, I've worked at 8 different institutions, public and private, big and small, 4-year and 2-year. My doctorate focused on the leadership of well-being programs, but I also have a master's degree in counseling. I'm not licensed and I don't work as a counselor. I work as a senior administrator overseeing our counseling department and our health services and health promotion departments. We have nurses, counselors, and health promotion staff on all 7 of our campuses. And each of those campuses have anywhere from 9,000 to 13,000 students. As Eunice mentioned, I'm co-editing a book with one of the people that was on my dissertation committee, and we are writing something like a dozen chapters with chapter authors on the leadership of well-being programs in universities and colleges across the United States. Today, I want to talk a little bit about the U.S. college and university context. I want to talk about the health and well-being context, and I want to talk a little bit about health and well-being leadership. I'm really interested in being able to present to you the U.S. higher ed system. Student affairs and academic affairs are a little different in the United States. I want to talk a little bit about how those are described and divided. I want to hear, maybe in your questions, reflections you have about well-being practices, and explore maybe opportunities for ongoing collaboration and international research if possible. I think there are some structural differences. And one of the things that's really, I think, pertinent in the US is that community colleges have lagged behind traditional 4-year institutions, sometimes by 10 or 20 years in putting best practices into place. And so some of the things that we would see in the environment that I'm in, we are quickly trying to catch up to 4-year institutions that are often much better funded. So to begin, And I'm not a constitutional scholar, I will tell you. I would not be the best expert on the Constitution, but one of the things that's really pertinent in the United States is that there is no central ministry of education. In fact, education is delegated to the states. And so decisions related to education and educational programs and what's in the curriculum, both at the K-12 level and also at the collegiate level, are really relegated or delegated to the states themselves. So there can be considerable differences in the ways that, for example, discussions about faculty tenure exist. States that are much more liberal, per se, blue states, may have a different focus on whether or not faculty should have tenure. In fact, I was at a dinner with some friends recently who are faculty members, and they were, concerned that in Texas, for example, we might actually see tenure being abolished at public institutions in Texas. And so with no central Ministry of Education, the states make decisions about education. The federal government provides support through various financial incentives, guaranteed student loans, and financial aid, but regulation actually occurs through private regional accreditation organizations. So for example, here in Texas, we are overseen by an accreditation organization called SACS. SACS is the Southern Association of Colleges. And that accreditation institution has a lot of power over regulating the different institutions of higher education. The Federal Department of Education was originally created as a very small department in 1867 to just help set up schools and gather information supporting teachers. But the current existing version of the Department of Education in the US wasn't established until 1980. In the US, these accreditation bodies are very powerful. They review programs. There's a cycle to it, typically 5 or 10 years. They come to your campus, you do an off-site review and then an on-site review. And so these accreditation organizations have a lot of influence, and institutions that want to be seen as high quality typically always participate in those regional accreditation review processes. In terms of types of institutions, things are a little different. I think that we are in the US maybe 100 times larger than the population of students enrolled in Finland. We have at least 16 million students enrolled. That's graduate and undergraduate, public and private. Where I work in a community college, even though I've worked in other four-year institutions, I've worked in a medical school with professional graduate level courses and programs, community colleges actually make up most of they are the largest single sector, but they also tend to be less selective. My institution, for example, accepts everyone that seeks to enroll. It's open enrollment. Like Eric mentioned, though, we are also seeing declines in enrollment progressively, and that's a significant concern. These types vary so greatly across the US. There are 4,000 degree granting post-secondary or post-high school level institutions. Public and private colleges are 4-year, universities are 4-year with graduate studies. Liberal arts colleges, like the one I attended, Hamilton, are focused on broad liberal learning. Research universities, they're for-profit colleges, focus mostly on the trades or technical education, nursing, and community colleges. And then there are also religiously affiliated colleges with the Lutheran or Baptist or Catholic churches. As you may know, there are all of the Ivy League institutions, and the Merrill Act in the mid-1800s created land-grant institutions. Those universities were formed on large swaths of land in developing states. Cornell, for example, is both a land-grant university and an Ivy League institution. And then there are all of the top research institutions like MIT, and often many technical and trade schools focused on applied learning like automotive, electrical, construction, and manufacturing. And perhaps the most significant difference is that within our universities, whether that's a 2-year institution or a 4-year institution, this probably is true to a varying degree, but it would be a general rule, is that student affairs is its own separate division. Just like, say, facilities management or financial services, business services, student affairs is its own very distinct large unit. And so programs like residence life, intramurals and recreation, athletics, accessibility services, student conduct, health and well-being, these are all part of student affairs in the United States. Academic affairs is everything that has to do with learning, faculty, libraries, academic instruction, the Center for Teaching and Learning, tutoring, often with some overlap and some differences between universities. These are very, very bifurcated. So student affairs is its own separate division, and all the faculty are their own separate division. And we work with limited touch points across those divides. And also in the United States, there's no national health service. And so many students, thanks to the Affordable Care Act, or what people call Obamacare, many students can now stay on their health insurance until they're 26 years old. But often lower income students, like those at my institution, simply don't have healthcare coverage because there's no national health service. And their parents, oftentimes because they're immigrants, or the students themselves are first generation college students, their parents don't have health insurance. And so many of our students at a community college, or a number of students across the US, simply don't have health insurance. Part of what was wonderful for the Affordable Care Act is for those that can afford it or those that have it, pre-existing conditions can be addressed, and there is typically coverage for mental health services. But if you don't have health insurance, that's a problem. In some states, a federal program, Medicaid, is available to students with limited incomes, but the states determine that, and it's limited by state, and it's different. So it depends where you are, and it depends whether or not students will have coverage. For example, at Dallas College, we don't require students to have health insurance coverage because we see that as a barrier to their enrollment in higher education. We do everything we can to refer them to low cost or sliding scale services or free services in the community that go beyond our services, but often they are without insurance. As Eric mentioned, similarly in the United States, many mental health concerns prior to the pandemic and post-pandemic. 40% of all students at colleges and universities in the US have a significant mental health problem. This was already emerging pre-pandemic and became even worse during the pandemic. We know that students with poor mental health and well-being are more likely to experience academic difficulties. And so in order to prioritize student learning, we have to prioritize student well-being. They are truly deeply connected. There are several, to get into the meat of it, there are several overarching national bodies for student affairs in the US, and those include NASPA, the National Association of Student Personnel Administrators, and ACPA, the American College Professionals Association. There are also several national bodies for health and well-being that operate kind of at the meta level, the National Wellness Institute and the Wellness Council of America. The latter is probably the primary employee wellness organization in the US. NASPA, this student affairs organization, has a number of knowledge communities, including one focused on health and wellness. But the American College Health Association really is the primary body for colleges and university health in the United States. Across different subsections like residence life, career services, intramurals and rec, there are their own professional organizations like NERSA, and those often have subcommittees or task forces associated with health and wellness. Some of the similarities between our two countries are that, we're all concerned with student health and well-being. We're interested in the ways that we communicate with students. We really hope to, I think, both address belongingness, loneliness, and mental health concerns. It sounds like you draw on professionals inside the university and also outside of the university for student health and wellness services. We're both concerned with evidence-based practices and measuring well-being. But in the US, counseling, accessibility services, health promotion, academic advising, these are very distinct disciplines. Not all of these actually are integrated into the health and wellness committees on every campus. They tend to be their own separate areas with their own extensive and expansive professional organizations. Collaboration can be exceptional and highly integrated and moving along very, very comprehensively at some institutions, and at others it can be very fragmented. Probably one of the best examples for where academic affairs and student affairs and other units come together is through what are called care teams. These are teams to address students of concern. And most of the care teams across the United States use something called the NABITA rubric. That's the National Association of Behavioral Intervention and Threat Assessment. And these manage acute student concerns that may have complicating mental health and maybe, potential loss to enrollment in their review of student needs. There also is a movement, an increasing movement to define what it means to have well-being in the United States. in 2020, all of these different professional organizations, something like a dozen or 14 of them, came together to foster an inter-association definition that they defined as an optimal or dynamic state that allows people to achieve their full potential. So there was some preliminary interaction among those organizations that culminated in 20 of them getting together in February, March of this year, hosting a large, free, virtual, nearly week-long conference that was intended to raise literacy and advance the conversation around well-being in higher education in the US. You know, again, just to put it, not too fine a point on it, but comparing Finland's COHO project versus the US, there really is no nationally coordinated project. There are many sub-projects like the US Health Promoting Campuses Network or universities that participate in the Okanagan Charter, but there's no nationally coordinated project. Guidance and counseling are not integrated. In fact, the last time I really thought of guidance and counseling being integrated in the United States was when I was an 8th grader 40 or 50 years ago. Then my guidance counselor was also somebody who, you know, not only helped me pick out my courses in middle school or in high school, but they were also somebody I could pop in and talk to if I had an emotional concern. But these are really different disciplines in the United States. Academic advising is a very structured guidance, kind of process. Whereas the counselors that are on our campuses are psychotherapy professionals. They typically are licensed professionals. At Dallas College, the 18 staff that we have across all 7 campuses are either licensed professional counselors, licensed marriage and family therapists, or licensed social workers. Only community colleges, really with limited funds, continue to have these be somewhat linked, and that's progressively changing. Health promotion and counseling are also seen as similarly distinctive fields. Eric asked me to talk a little bit about surveys, and there's a proliferation of surveys in the United States. The best known is probably the American College Health Association National Collegiate Health Assessment, but increasingly the Healthy Minds Network and mental health survey is emerging as a competitor to the NCHA. There are also other surveys like the Hope Center Survey of Basic Needs, looking at housing and transportation and emergency financial assistance, and the Trellis Financial Survey. And at Dallas College, we've done several of these, 3 of these, and have integrated them into a comprehensive report that helps us better understand our student population. But to focus for a few minutes on the American College Health Association, American College Health Association advocates for college health. 700 institutions of higher education, 19 million students have participate, 11,000 professionals participate. So it is the broadest organization in the US participating in college health. And they break down into regional affiliates, parts of the US, broad parts, the Southwest College Health Association, the New York State College Health Association. There are interest area coalitions like the Community College Health Coalition that I formed, an alcohol, tobacco, and other drug coalition. There are task forces like the Reproductive Rights Task Force, and also something called the Associate Vice President, Associate Vice Provost, or Associate Vice Chancellor Health and Wellbeing Task Force, and I'll talk a little bit more about that in a second. That's in the process of emerging as a section, which is discipline-based, the administration, clinical medicine, health promotion, mental health, etc. They provide a host of programs and services, the NCHA, a faculty and staff assessment, a patient satisfaction survey. They provide consulting, and they have their own distinct framework for college health. That's a collective impact framework. They have a leadership institute that they have sunsetted, and they also have a data hub that lets participating institutions better have benchmarks for funding and staffing, etc. The NCHA is a nationally recognized research survey that looks at a number of different indicators. 2.2 million students have taken it at over 1,000 colleges. Some, like several that I've worked at, have conducted it multiple times. 500 plus schools have done that to have longitudinal data. And today, any of you could go on to their website and download the semesterly executive report and look at that and compare it to your own data in Finland. In fact, they are eager to have people access their data and conduct research. So if any of you are researchers or interested in conducting research that is cross, institutional and cross-national, transnational, this would be a wonderful way for you to access some data easily. This is what it looks like. I just show a couple of slides. You can see that it focuses on things like physical well-being, healthcare utilization, impediments to academic performance, violence, ATOD, sexual health, mental health, acute and chronic conditions. And it looks deeply at what these impediments to academic performance are, like procrastination, finances, career concerns, relational issues. It also looks at socio-emotional impediments like anxiety, depression, sleep difficulties, and stress. And these are for the something like 30,000 students that took it in the fall of 2023. In terms of mental health and well-being, specific scales are built in, so it's a very robust survey, the Kessler-6, a loneliness scale, the flourishing scale, the Connor-Davidson resilience scale, and it gives great data on stress and suicidality. You can see that something like close to 80% of students in the US reported moderate to high stress in the last 30 days. A little over 2% said they had attempted suicide in the last 12 months, I think, with 6+% of trans and gender non-conforming students indicating that their lives were impacted by a suicide attempt. NCHA does not necessarily collect outright measures of belongingness, peer support, and community. It also does not address things like learning skills and learning disabilities. It doesn't address pedagogy or training staff and well-being. But we have seen that, multi-professional collaboration across peer communities, professional organizations, really is starting to change a little bit. And I didn't want to forget to indicate that basic care and needs really at institutions like a community college, but increasingly across four-year institutions and even in medical schools and professional health professions schools, we're seeing that all of these topics and concerns are a critical need across the United States. Where we are seeing some traction for pedagogical well-being and connection across academic affairs and student affairs is that increasingly health promotion professionals are helping to develop guidebooks for academic affairs, working often with their centers for teaching and learning. Simon Fraser in the Northwest, Pacific Northwest in Canada, were the first that I saw to create this guidebook for well-being and learning environments. They are the gold standard, but others like UT Austin, one of the best public institutions in Texas, took some of their ideas and really ran with it, creating their own guidebook. Other institutions like Washington University in St. Louis and UC Davis are also developing their own guidebooks that help cross these different divisions in the United States. They cover topics like social connection for faculty, how faculty can enhance compassion and stress reduction, helping to foster a sense of belongingness and growth mindset in their classrooms, enhancing gratitude and purpose among students, and specifically where there are students in distress, helping them understand how do I get those students connected to care teams and counseling centers. Finally, I want to focus a little bit for 5 minutes or so on my own, my own research. One of the things that I looked at in the United States, there's this emerging term called Chief Wellness Officer. That's typically somebody who is a vice president or one of these AVCs who holds a portfolio of departments like counseling, health services, health promotion, basic care and needs. Bill Fox, a good colleague of mine, was the first to write a dissertation on a single case study at The Ohio University. He and other researchers noted an increasing need that existed for this type of cross-functional leadership. And during the pandemic, these people in these roles were increasingly tasked with leading COVID response. They saw it as an emergent role, one that could catalyze well-being efforts, addressing not only student well-being, but employee well-being and other strategic concerns across our institutions. Often it will be the case like a large school like the Ohio State University or Cornell will have multiple colleges, as you may as well in Finland, but also have a law school and a medical school and employee well-being needs that are all needing some type of integration. I took it the next step and I did a qualitative collective case study of well-being leadership across 6 diverse regional campuses in the United States, 19 interviews. These were public and private institutions, large and small. One was a medical school within a large public institution. And what I found was, and what drove my research was that there was really limited research. Bill had only done the first dissertation on this topic. He used an organizational development integrated change model, which is a fairly typical traditional organizational development approach. It looked at issues that were important to the Ohio State University: chronic disease, healthy lifestyles, rising healthcare costs, ROI, but that did not represent my experience at 8 institutions in the United States. I really felt that well-being leadership was very complex. It really depended upon the nature of the institution. Because higher ed is so different, There might be a school like one that I've worked at with 3,000 students. It's rural. It has a big Greek life population. There's a lot of abuse of alcohol and concomitant sexual violence concerns. Students are rural, so there's not a lot to do. They have Division I sports versus a large 100,000 student campus-based community college like the one I work at. The concerns that were associated with those different types of environments were very different from each other. And I thought that that required a different thought about how to approach well-being on those campuses. I was really interested in relational dynamics, collaboration, and the way that we co-construct meaning. Going back to my undergraduate degree in anthropology, I really think about the culture of the institution and the way that we create meaning, and I thought that was under-described in that research. So my conceptual framework looked at these four theories and approaches. I'll focus on two for a second. Relational leadership theory thinks about leadership as something that's socially constructed. It's something that people do together. It's embedded in the context of how we make meaning of the programs that we develop. I think of it, it's described as a collective social practice where the way that people engage in dialogue helps to create what we agree is the meaningful component and what's purposeful. Social constructionism, largely led in the US by the Taos Institute, says that the world is something that we construct. It's a phenomenon contingent upon the way that we create collective meaning formed through our relationships. Leadership is seen as an aspect of community. That's kind of an esoteric way of describing that we work in a culture together that can be different in different campuses. And it means that we define how we create a program of interaction that will address those students' well-being needs in different ways. It's a postmodern epistemology, social constructionism. It's something where knowledge is generated between groups of people, and those solutions are socially embedded. Leadership really, for me, is a form of community engagement with the people who are working on those types of programs. And so I wanted to know how the people who were, quote unquote, the leaders and the community members thought about leadership. I asked questions about how people work together to influence the development of their well-being programs. I asked how they perceive the role of communications. And this drew on a meta-study that Andre and Weibler did related to relational social constructionist leadership. I drew on some of their mechanism and their ideas in the development of my research questions. And Eunice can put this in the chat. I'd be happy to share the article that I first published from my dissertation related to the findings. And what we saw, and it's very, cursory review and description of it, is that there were three primary areas of findings. One that had to do the way that effective leaders in conjunction with their community members developed leadership and strategic approaches. They also collaborated in particular ways, and they worked effectively to address communications in their environment. In terms of the leadership and strategy, they exerted influence in a really unique way. They were very strategic. They focused heavily on team member development. They made people feel like they really were valuable. Effective leaders collaborated not only very carefully on one-on-one relationships, but also through broader collaboratives that they help foster and develop. They emphasize creativity and innovation extensively. And often in terms of communication, as we have here at Dallas College, they had an embedded communications person, a marketing professional that either part-time or full-time was associated with their well-being program broadly. And they worked very hard to create embedded communication strategies that focus on how they developed a sense of what it was that everybody was talking about. They made very clear what the brand was about at their institution and what it tried to address and how that was meaningful for the population there. Not only the people that were on their well-being committee, but also the broader population of their students. And they really emphasized kind of everybody's voice, enhancing dialogue within their community. And from that, I created my own model, the Wellbeing Social Constructionist model, that looks at these unique campus-based cultures, their barriers, the way that community members and leaders work together across these three areas. And in the United States, one of the things that we're really seeing is that historically, 20 years ago, if we were talking about well-being, we would have been talking about physical well-being. We would have been talking about exercise, nutrition, sleep. But increasingly, what we're seeing is the emergence of diversity, equity, and inclusion, particularly related to health equity, social determinants of health, and that's converging. We're really seeing an increasing influence of the way that and multidimensional well-being are converging within these environments. And so in my research, I looked at that and found that as a finding and tried to describe it. One of the things that I quickly, as Eric was talking, I pulled into my slideshow is this slide that represents the way that we address well-being at Dallas College. It situates the student and their success coach within the right big circle, which is all of the units in our Division of Student Affairs who are connected with all of the other outlying academic affairs supports, including special academic programs, academic scheduling, guided pathways, and the partnerships that we have in the community related to career and employer partnerships, and also related to the partnerships that we have helping students receive care that goes beyond the scope of our nurses, for example, or our counselors at Dallas College. And that goes back and links to the pre-collegiate experience, including for us, particularly high school partnerships, college coaches that help draw people into their college learning experience. So we have a very specific model, I think, that Eric was starting to reference. And I just wanted to throw that in there because we do have a very unique way of addressing that at our institution. I had a few recommendations from this study. You know, I really wanted to emphasize the importance of collaborative work. I suggest that we need to fund additional research, asking students themselves about the benefits of the programs on their unique campuses. There are different approaches in the US. Some are unit-based, some are collaboratives, like Cornell using the Okanagan Charter. Others are portfolio-based. I really wanted to see a study that explored whether or not these different approaches had unique benefits or were more effective. I think there needed to be more training in collaborative approaches like design thinking for leaders and community members. In the US, we have standards of practice for health promotion under ACHA. We really need a similar standard of practice for the well-being leader. And then finally, I wanted us to explore the experiences of diverse populations and whether or not they felt that the campus well-being programs were meeting their needs. At Dallas College, 85% of our students come from what we would call diverse non-majority populations. We are an HSI, a Hispanic serving institution. And so, you know, we need more information about whether or not what we're offering really meets students' needs. A few final thoughts, you know, in terms of your own health and well-being leadership and connection to anything in the US, you might, for example, next week is the American College Health Association annual meeting in Atlanta. You might consider attending that. The US Health Promoting Campuses Network is linked to the International Health Promoting Campuses Network. So connecting through that to the US member institutions who are implementing the Okanagan Charter. And there will be, I think, very good research and connection coming soon from this task force through ACHA among these leaders who will be converting the task force into a section soon. I'm hoping that there will be good research and opportunities for collaboration. And with that, I'm going to stop sharing. That's everything today. Thank you so much.
Thank you, Thad. I don't see any questions yet in the Q&A, so please feel to share there, and I'll ask those away. But I did prepare a few questions as I promised in the beginning that to get the conversation starting, and they're more focused on this idea of a wellness chief wellness officer, a particular leader for wellness or well-being. What would be your main arguments for establishing just kind of a managerial position in a higher education institution?
That's a great question. So I'll speak to my current experience. You know, at our institution at Dallas College, I work under an associate vice chancellor, a student affairs professional who himself has a doctorate in higher ed administration and leadership. And under him, I'm one of two deans that oversee different areas. For us in the United States, and particularly at this kind of an institution that's so big, we have so many different units that are working tirelessly to support our students. But often those, there can be an enhanced opportunity to collaborate and create solutions for students that would emerge from coordinated operations. And so I think, you know, in the United States, our institutions are very diverse in terms of their organizational structure, the numbers of students. Some institutions like those that I attended and those that I've worked at, like Colgate and Hamilton, have huge endowments. They have billion-dollar endowments, but they don't always have as many staff to do the work. At Dallas College, we really have invested heavily in our staff, but we're dispersed across 7 campuses, across a large metropolitan area. So having someone in that role who can coordinate and drive the vision and help us effectively collaborate together is really, I think, critical.
and to kind of follow up there, what kind of processes, services, or resources should just such a leader have?
Yeah, well, I think, some of the best leaders, I'm thinking of the Ohio State University example because they've been doing it for so long. Bern Melnick and others there, Megan Amaya, they have developed an incredible strategic plan. You can find it if you do a Google search. It may also be on their website. And with a little bit of time, I can share it with Eunice and you, Eric, and you can share it back out with the attendees. But their strategic plan really operationalizes all of the different key goals and KPIs that they want to try and address. The University of Southern California, their health and well-being program also has a really, really robust identification of the key performance indicators that they're trying to address, including those related to things like mental health, belongingness, et cetera. And so I can easily share back both of those links and details. It really helps, having a person in this role who can drive the clarification, because it's very easy, I think, for example, at Dallas College, we are relatively new to being integrated as one single institution. And so part of what has happened over the last 3 or 4 years is that it's been a challenge to really define how do we address all of the needs that exist. Basic care needs are so incredibly fundamental. Our students are really struggling with some of those. And how do we do that effectively? Having a good strategic plan is really critical.
But in terms of staffing, do you think it's important that the chief wellness officer has people that directly report to him and work for him?
Yeah, absolutely. In our case, let me elaborate on that a little bit. As you heard me say, I oversee counseling, health services, and health promotion. That's about 40, 45 people. And my counterpart on the other side, the dean over basic care and needs, also has 2 leaders under her, and then another 20 to 40 staff members who are addressing critical care concerns. So yeah, having the appropriate staffing structure, and that's why I really want to promote a little bit. I'm an unpaid endorser here, but the American College Health Association has this data hub that looks at the institutional profiles and helps institutions determine their own benchmarks for comparison institutions for whether or not they, what their budget might be per FTE, full-time equivalent employee, and how many, staff members are present at institutions that say have 30,000 students. How many counseling staff members are there? How many nurses and health professionals are there? Things like that have helped us really begin to benchmark in the United States how many staff members are necessary to do this work well.
Now, as you might know, in the Finnish context, we have the healthcare system for the students it's not remote from the higher institutions of education, but of course they're not organizationally part of that. How do you see that? If there would be a Finnish chief wellness officer, and we have those kind of roles already, but how would that make a difference if you don't have the healthcare component there?
Here's what I think is really interesting about the place that I work currently, and it would be relevant at, for example, the small private liberal arts institution I worked at as well, that was very rural. We often cannot, large public institutions in the United States, let me say the University of North Texas, which is in the town that I live in, they have 40,000 students, and they might have 50 people in their health center, including doctors and psychiatrists and a whole range of health professionals. Compared to Finland, I think that institutions like I'm at, the Dallas College or Colgate, for example, we often don't have that full slate of health professionals. And so the chief wellness officer and their subordinates are often galvanizing connections to the community for services that go beyond the scope. We are short-term brief therapy in our counseling centers, and we refer out to community partners for psychiatric services, for medication management. And so in Finland, I would imagine that the chief wellness officer might be the key person galvanizing referrals to not only your National Health Service, but enhancing that relationship and enhancing the ability of students at the university to be connected and fully engage.
So can it be a bridge builder more to?
Correct.
Yeah.
Correct. Yeah.
So what not to do? So if somebody's listening, they're contemplating whether we should roll out a chief wellness officer in our institution. What would you not do? Are there some like bad examples, or of course you don't have to name the institution, but something that maybe was done and it didn't work out and then had to go back to the drawing board?
Yeah, I have seen at a couple of institutions try to implement well-being programs and have them kind of flounder a little bit or not be fully implemented. I think it helps to initially have a very good conversation among all of your stakeholders to understand what the stakeholders are willing to support. Because if, for example, a senior leader implements or makes a decision, say the president makes a decision of the university that we're going to hire somebody in this role, but there have been prior failed attempts, or the university is too fragmented or doesn't support a presidentially led implemented position, that can be confounding. Having it be something that really includes all of the voices of all of the members in the community who are stakeholders, I think is really critical. I think also understanding that just by hiring somebody doesn't necessarily mean that they are the best person for, you can hire somebody into the role, but I think it really takes somebody with the right qualities to lead these kinds of programs. And I think we're in the process of learning what that's about. With the pandemic in the US, many counseling center directors emerged into these roles. But counseling center directors don't have a lot of experience, and I'm not trying to knock them. I'm a counselor myself. They don't often have a lot of experience with public health approaches necessarily. They don't often have experience with health promotion. There are units that they haven't necessarily supervised. So making sure that those who are hired for, if they are counseling center directors, are people who have broad understanding of public health, upstream interventions, things like the socio-ecological model, health promotion models, et cetera, I think is really critical. And that there's somebody who can galvanize a community around a central model, like, for example, the Okanagan Charter. That can be many people from many different professional areas. It could be anyone, intramurals and rec, it could be counseling, it could be health promotion, it could be social work in the United States, but they have to be somebody who can be successful in galvanizing community engagement internally and externally.
We have 2 questions. Let's see, we'll have a little bit of time left. You mentioned helping teachers support students with stress management. Do you have any examples of that?
Yeah, many schools, and I'll spotlight one at UT Austin. UT Austin, University of Texas at Austin, has a large, they're a large school, 40,000, I think, plus, and they have a large staff associated with their health and wellness. They may even have 20 staff members just associated with health promotion, individuals who are only responsible for sexual violence prevention, alcohol and other drugs. Like, that's their full job. They have hired one person, and that person's sole responsibility is to oversee the implementation of well-being programs in academic settings as the liaison from student affairs to academics. And so that person working with counseling at that institution, or there are examples across the US where the counseling center will partner with the Center for Teaching and Learning, which is our faculty professional development center, implementing practices, quick practices to teach faculty to create environments that are stress-free. Another example at Syracuse University, my colleague there, they're going to spend 2 minutes in one of their schools where they're going to do, I believe, implementing stress reduction or other well-being interventions at the beginning of every class in the School of Education.
Interesting. I think we have time for one more. There's a thank you for an interesting presentation. And
yeah,
you mentioned design thinking. So what kind of possibilities do the current students have to participate in designing services for their well-being? Do you have a...
Yeah, I think that really depends upon the institution. Many institutions in the United States, peer health educators are very, very intensively involved in health promotion. They often form the backbone in lieu of other full-time professionals. Some institutions have students who participate on what are called SHACs, the Student Health Advisory Committees. And so students often play an important role in influencing the development of health and well-being programs. It really just depends on the institution. Historically, one of the institutions I was at, SUNY Oswego, and I really want to give a shout out to my co-coordinator there, Shelley Sloan at that time. She, with me as a kind of a support to her, ran, a peer education program that included a cohort of 20 students annually who did intensive and incredible outreach and training and education and helped with the planning process on the campus. And so, I think that there are many, many models for that in the United States.
Well, thank you for that. And I think, Jonas, we're probably going to end it here. Or do you have some final thoughts you want to share? I just want to thank for my part.
Thanks for you both. It's been a pleasure to have you present here, and thank you, Thad, for your keynote, and all the participants for their time watching this. I posted the webinar feedback link on the chat, so I hope you take a few minutes to fill that out, and everyone have a good day, and thank you all.
Thank you.
Thank you, everyone. Bye-bye.